this imaging presentation and also in our clinical practice. What is the problem of the 2D imaging? We have been using 2D imaging for such a long time. And here you can see that the 2D imaging that we have frequently used, like cephalogram or occlusal view, to see that in this patient, he has prognatism and facial asymmetry. And using the 2D imaging, it is not easy to describe what was the problem. And in this occlusal film, this is after the alveolar bone graft. And you can see the bone graft there, but you don't know how much the bone graft is in the alveolar cleft area. So in terms of the landmark identification, structure, overlapping, and also measurement is not easy. So to use the 2D imaging, we actually have been doing a lot of bone graft, have been experienced a lot of limitation in using this 2D. You don't know how much now bone graft is. This is a case with 3D imaging. So in terms of this case, receive identification, structure, the overlapping A, and also measurement is not planning. And image B is actual to use the 2D image. We actually have been so you can a lot of these two images by superposition, a lot of limitation image in using this simulation. Now, this is in the case, and then what you can 3D imaging in terms of how much accurate receive identification. Structure, deviation, the difference, overlapping A and also measurement simulation that shown using the color match B to actual to use the 2D image actually have so qualitative. So you can compare this image has been treated by superposition, a lot of limitation image. What do we need simulation now? This is in the case, and then what you can 3D imaging and in terms of how much accurate receive identification structure, deviation, the difference overlapping A and also measurement simulation that shown using the color match B to use the 2D image actually have so the image qualitative. So you can a lot of music image has been turned by a lot of limitation image. What do we need now to see? This is in the case, and then you can 3D imaging and then simulate accurate receive and also structure deviation the difference overlapping A and also measurement simulation that shown using the color match and also use the 3D laser image actually have so the image for the music image has been turned by a lot of limitation image. What do we need now to see? This is the case, and then you can 3D imaging and then simulate and also structure deviation for difference overlapping A and also measurement simulation that shown using the color match and also use the 3D laser image and suddenly the image for the laser system by a lot of limitation. What do we need now from this is the case, and then you can 3D imaging and then simulate and also structure deviation for difference between A and also some of the structures that shown within the color and also use the laser image and suddenly the image for the one of the software by a lot of limitation. What do we need now from this is the case, and then you can 3D imaging and then simulate and also structure deviation for difference between A and also it is that shown with the color and also use for the laser imaging. And certainly equality for the patient subjects. This is one of the software because of limitation. What do we mean by now program? This is the basic fundamental way you can differentiate specific software range of difference between A and also it is that and also used for the laser and certainly equality for the patient subjects. This is one of the software because of limitation. What do we mean by now program? This is the basic fundamental way you can differentiate specific software range also difference between A and also it is that and also used for the laser and certainly equality for the patient subjects. This is one of the software because of limitation. What do we mean by now program? This is the basic fundamental way you can differentiate specific software range also difference between A and it is that and also used for the laser and certainly equality for the patient subjects. This is one of the software because of limitation. What do we mean by now program? This is the basic fundamental way you can differentiate specific software range also difference between A and it is that and also used for the laser and certainly equality for the patient subjects. This is one of the software what do we mean by this is the basic fundamental way you can differentiate specific software range also difference between A and it is that and also used for the laser because in our surgery or if you do dental implant, I think you better evaluate the inferior alveolar nerve very accurately so that you don't injure the inferior alveolar nerve. And we can see the skeletal and soft tissue that is skin surface relationship. So what is the movement between the bone and the skin surface. Now, this is just a simple example to evaluate the inferior alveolar nerve within the mandible. Now, in the upper part, you see this is the panorax. This is very commonly used. However, panorax, you can see where is the nerve, but this is not an accurate 3D. So in the clinical practice, it's difficult to guess, to evaluate where exactly is the nerve located. But if you have a 3D, you can actually extract slice by slice within the bone, and then put it together. You can see the course from entrance to the exit of the inferior alveolar nerve. Now these the 3D program, for example, the Dolphin 3D can easily do that task for you before the treatment. So you can see each level where is the nerve located when you do the orthodontic surgery, when you do the anterior segmental osteotomy, or you do bone shaving to do bone reduction, dental implant, you can see very clear where is the entrance of the nerve, like sigmoid notch to the entrance. Or if you do a vertical osteotomy, then you need to do it behind the nerve. Then you need to measure the nerve to the posterior border. So, and also you can measure the exit of the inferior alveolar nerve into mental nerve, because the nerve always go inferior, anterior, and then coming out from the mental foramen. So if you do genioplasty, you need to avoid injuring the nerve. So this kind of measurement that could give you a very nice anatomical relationship before the surgery. When you do the planning, and actually during the surgery, you can see the data from it. For example, here, I measure a group of patients, so I can see in each level an angle, the first molar, second molar, where is the nerve with relationship to the anterior border, posterior border, and lateral border. So these data are very helpful for my practice when I do the mandibular surgery, osteotomy, reduction, or segmental osteotomy as well. Now, not only the nerve, the soft tissue structure, but also the hemifacial microsomia. This case is the case of a hemifacial microsomia. She came to me to have so-called the cosmetic, to improve the cosmetic appearance. Then I told her that you may receive orthodontic surgery, or you may just do we can do contouring surgery for you. Certainly, these two surgery are different surgery, and she finally chose to receive contouring surgery. So with the 3D here, I said, okay, I can reduce your right side mandibular border, and I can increase your left side. I can so-called I can create a mandibular angle to your left side, and also I can evaluate the soft tissue difference, so that I can do the fat injection to improve the symmetry on both sides. So here is the result after reduction of the right side mandibular angle, bone graft to create left side mandibular angle, and also I did fat injection. The zygoma actually from both sides are quite similar, so I didn't touch her zygoma. Here is the result before and after the surgery, and I actually could increase the bone in the left mandibular angle here before and after, and I also do a genioplasty to improve the chin. Now, almost every day we do this 3D simulation for our orthodontic surgery. In my center, we do many orthodontic surgery in our practice, almost 600 cases a year. And every case we do before the surgery, we do 3D simulation using the Dolphin. Some other doctor use other software because for me, I personally prefer to use Dolphin 3D software. I feel that it is easy and user friendly, and actually it's not expensive. Now this is a lady, a typical common young lady with class 3 malocclusion, and she came for orthodontic surgery in order to improve the occlusal relationship as well as to improve the facial appearance. So we step by step we do this surgical simulation. This is also using the Dolphin and the default one and BSSO and genioplasty, has been defined already. So this after definition, these are individual object or segment. So we can easily mobilize to move this segment. So the first step, we move the mandible. You can see here, move the mandible to occlude with the maxilla. So this is the final occlusal relationship that is performed by our orthodontist. Then we have this compress between the maxilla and mandible. We call it maxillomandibular compress. So we move this maxillomandibular compress to its good position. And this also, of course, we have 3D cephalometric data in order to move the maxillomandibular complex. And then as a surgeon, I do the last adjustment because I wish to achieve the symmetry and also achieve the facial symmetry, and also to reduce if there is any bony collision, and also I wish that in terms of the surgery, it's easier to perform. So the lateral view, first step, and then second step, mobilize the maxillomandibular complex, and then do the last refinement. So including a genioplasty, and you can see that anterior occlusal relationship is close. The posterior occlusal view, posterior occlusion is open, but it is easy to correct the posterior open bite orthodontically. So the first step, second step, and the last step to improve the symmetry from both sides. In this case, you can see improvement in the lower mandibular border. And also in the basal view, to see step by step, it is symmetry from both sides. And also, I would like to see here, to see how much advancement and how much difference between the so-called PMJ, pterygoid maxillary junction, and also to look at the pterygoid maxillary junction, so that when I perform the Level 1, I have a clear idea when to disimpact the pterygoid-mandibular junction here. And sometimes I even do a setback. So, and also this also let me have the idea to how to fracture the pterygoid process in order to set back the maxilla. So now here give me the some data to do the measurement, how much advancement here, Level 1, and also some area shortening, some area opening. So these are the detail that so-called surgical blueprint. And also I measure the setback portion of the mandible, and during the surgery I would remove the posterior part of the distal cortex, so that I could reduce the relapse, reduce the soft tissue resistance, and also by resecting the posterior part, I could detach the medial pterygoid muscle so that the whole mandible become relaxed. So these are the very good surgical information for me before the surgery, a very clear anatomical relationship before the surgery. So this is much better than before when we were using the 2D cephalometry. And also here I mark the inferior alveolar nerve here. So when I do the mandibular ramus split, I could avoid injuring the inferior alveolar nerve. This is in the right side, and this is in the left side. This is a more commonly happen that the nerve is in the medial part of the ramus. in the ankle area. So when I split the mandible, it's easy not to injure. But even if I see before the surgery, the nerve is in the middle, I could still carefully open the split and open the ramus and preserve the nerve in order not to injure the nerve. So this is a very nice information when we do the ramus splitting and not to injure the inferior alveolar nerve. So here is the lady after the surgery, and the mandible maxilla has been moved to a more ideal location and fixed. And here the proportion and symmetry of the face has been achieved, and she feel happy, and she the whole treatment course is smooth and resulted in a nice outcome. Now, even when we have a complicated case like Cruzon or Epert-Pfeiffer syndrome, if we do lymphocyte destruction, this is a case of Cruzon syndrome, and I did cranial remodeling when he was an infant, about 1 year old. And now he was about 6-7 years old. And you can see a Cruzon syndrome, the midface protrusion is very severe, very small mandible and midface, very significant class 3 malocclusion. And the left side is our cephalometry, the right side is the 3D CT. And now you can very easy to tell the anatomical relationship when we perform the default 3 destruction, osteotomy and destruction. And we can also print the CT data. So we have this the physical model, and we can actually mark, or we can even perform the default 3 surgery before in this on this model. So that could help to achieve surgical safety and to reduce the complication and also to reduce the bleeding. And here is the patient after default 3 osteotomy, and we use external rigid fixation and gradual forward destruction here. And we destruct much more than he needs. We call it overcorrection. And here is before and after the surgery. And you can see here from class 3 to class 2, this is overcorrection. And a very nice result, because in this he will grow, he will continue to grow, but the midface will not grow, will stop there. So by doing overcorrection, we can achieve this nice result. And we also have other situation, a difficult situation that we could apply 3D imaging and also the 3D printing to perform. For example, in this case with Naegeli syndrome, we did this mandible destruction, and my previous fellow, a Korean fellow, he performed the image manipulation and printing. So this case with Naegeli syndrome is it was 6 years of age, and she is about to enter primary school, and the mother came to me for the improvement of the mandible, improvement the airway, and reduce the obstructive sleep apnea, so that she could go to school. So before the surgery, this is the 3D, and we injure
Recording
the
in
nerve, and
progress.
I do not injure the tooth spot. So this is the my osteotomy line, and also my so-called vector of the destruction. What direction I need to destruct the distal mandible, and also the osteotomy osteotomy line. So I designed this cutting guide and also the the positioning guide to place my screw positioning guide and also the cutting guide here. So this is the 3D model and also the positioning guide for this for this girl. So the left side, right side, and then during the surgery, and also insert of the external disruptor from both sides, and then start to do the destruction. You can see again, this is overcorrection of the mandible from the left side to the right side, and you can see that her mandible is lengthened much more than he need at his age. So this is a 3D image before and after surgery, and the lateral view, and the lady, the same young lady before and after treatment. And you can see we significantly improved the airway before and after. So she no longer have the obstructive sleep apnea. And you can see that the 3D imaging, we can use it for planning, and we can also use it to evaluate, in this case, the airway, because we can use the difference of the threshold between the bone and the soft tissue and also the air. So it's easy to measure the airway in this case. Now, this is another case example that I would like to show how we apply the 3D to perform the diagnosis and also the treatment. This lady, about 45 years of age, complained gradual jaw deviation and also inadequate mouth opening. So when she had a CT, we found a tumor attached to the skull base and also to the condyle. And this is not a common case. This is osteochondroma. So with the CT, we can delineate the extension, the location of the nerve, because this tumor invade the condyle and also the skull base. So I had to be careful and then ask the neurosurgeon to participate. So we open the temporal bone and then protect the temporal lobe, the brain, and then gradually, piece by piece, to remove the tumor, the osteochondroma. And then so this patient do not have condyle after the surgery, but I did not want to do condyle reconstruction because there's no bone in the skull base as well. So just let it as a free, as an empty space there. And by doing that, she could start to open the mouth and start to eat. So here you can see after the operation, she lost her condyle because that's a tumor involvement. So you can see here before and after, the tumor was removed, and she actually have some new condyle regenerate, but partially regenerate, but not full. This is the after the operation, she could eventually achieve a good facial symmetry, and also she could open her mouth, and then eating without difficulty. So with the image, we can do quantitative and qualitative purpose. We can do preoperative, postoperative, and also morphological study. So this is clinical orientation, and also you can have a so-called research purpose. So you can also not only evaluate bone, but also evaluate soft tissue, like for example, brain, CSF, eyeball, muscle, also air. So that's because you can, in the machine, you can adjust the threshold so that you can show display each different tissue, and then using the threshold technique to separate the different tissue. So what you need is a table, a computer, a PC, a personal computer, and also a software to work here. Now, we could extend using the 3D imaging. For example, in the orthodontic surgery, we can design the surgical plane, do 3D simulation, and then we can design the positioning guide to cut the default one and to position the default one segment. And also we can use navigation, contact or non-contact navigation. For example, on the right side, this is we call it brain lab, and some neurosurgeons use that for their intracranial operation. And we can also use here like a GPS, okay? We can position the maxillomandibular complex, and then using this sensor to tell me where is the location, the new location of the maxillomandibular complex. So a lot of application that we can use if we have this 3D imaging here. This is also, we need some software, computer software, to design the positioning guide. And this positioning guide help me to have the accurate repositioning of the default one segment. And there's also already a drill hole so that we can put the screw there. So this is a design. Just my research assistant will help to do this design before the surgery, and you can put this, put this right side, left side, and patient's number. So you can print, and then you can test if the positioning guide is accurate. And then during the surgery, just do the positioning guide, and then you can fix here, and then you can retract patient's soft tissue, and then evaluate the whole face to check if the facial symmetry, incisor exposure, or chin position is good. So so this could help intraoperative assessment if the whole face, the maxillomandibular complex, is in the ideal position. So then you can do the final fixation and then remove the positioning guide. Now this is a case that we have performed the surgical simulation, and then we also produce this positioning guide, and then we use the so-called surgical navigation using the brain lab, and this is the tracker fixation to the frontal area, and then do the intraoperative validation here. Certainly before the surgery, the night before surgery, we need to identify the landmark before, and then identify and then mark the landmark in a different way, and then do the before one and positioning guide, and then using the prop to see the the position of the maxilla, see if it is in the required position according to our planning. So, and then if it is yes, and then we can fix the position here. When you use the prop, it tells you how much difference between the, the up and down and left and right, and even the rotation area. And then if this is the right position, then we can fix. So here, this is the case before and after the operation here. And we can also check if the operation was accurately performed by superimposition between the surgical plan and the actual post-operative image. And then the color map will provide the accuracy after the superimposition. So again, this image lab, we need the image data. Very often is the CBCT data. Currently, we also have 3D photogram, and you only need a computer. 3D-MD is a 3D photograph that we are using for a number of years to see the skin surface. And we have a dental model scanner, and also we have intraoral scanner that if you have intraoral scanner, that then you do not need to produce the stone model. So I think this is all my talk using this 3D imaging in my clinical practice. And I know maybe some of you already have 3D imaging, and then you can step by step to increase your hardware, your facility, and also your software. If in the beginning you could not available to have the 3D printer, you can do outsourcing. If you are a frequent user, then maybe it's good time that you also purchase a 3D printer for your use. And I think the data bank is also important here. And we actually have a data bank. You can you need to consult engineer, computer engineer, or data specialist that how to save, how to keep all your image data in a safe place. You need a room, a small room, and also a hard disk there to keep your data, because if you have a large number of patients, and certainly you need to manage your data storage very carefully, so you can keep the data forever. And if you do the digital medicine or in the dentistry, then you actually do not need a physical material that like cephalometry. You don't need any film. You don't need a dental cask. Okay, so I think everything has become convenient, and you don't even need a so-called your dental lab to produce an occlusal spring, because the occlusal spring nowadays in our practice is completely digitized. And then we just output our data and then get to our 3D printer to have an occlusal spring. So I hope this talk is helpful for many of you, as you are in the dental field, working in this area. So we are also Sam. We have. I'm a surgeon, but I also have orthodontists. I have engineer people to work with me together. So this conclude my talk. I would like to answer any question. Thank you.
Thank you very much, Professor Low, for your really excellent presentation. And then now we come to the discussion session. So for all you guys, participants or distinguished guests who want to ask any question to Professor Low, you can type your question in the room chat, or you can raise your hand so you can talk directly to Professor Low. Really excellent and a brilliant presentation. We have one question, Professor. I will read it for you from Dr. Fadil Ulum Arrahman. Very insightful presentation, Professor Low, about how we apply 3D imaging and computer-aided design. But I'm curious, based on your experience, on your research, is there any influence of the type of imaging data source, or the type of software on the quality of design, like CBCT or CT scan, maybe? Is there any influence of the type of imaging data source or the type of software on the quality of design?
Okay, I think in the in one of my slides, I explained that I think the 3D data, the most commonly used is the CBCT data, combined CT data. I think combined CT data is good enough for our daily practice in dental and maxillofacial area region. Certainly, you can also use CT scanner in the radiology department. But I think the CT scanner, the radiation dose is higher, and CBCT, the radiation is lower, and also the resolution is good enough to produce like occlusal spring, and also the physical model. So I think the quality of CBCT is good enough. Certainly, if you have intraoral scan, that intraoral scan should be used to replace the teeth in the CBCT, because the teeth in the CBCT is not good enough to produce the occlusal spring. Or you can obtain a stone model, dental stone model, impression and stone model, and you can scan your model, and that then you can have a good dentition to replace the teeth in the CBCT. So this is important, that the CBCT, the dentition is no good. You cannot use it. And number one is the resolution is not good enough. Number two, sometimes they are bracket, sometimes they are metal, there's artifact. So you should have a so-called the dental scan to replace the teeth in the CBCT, and that is good enough. And also the data, not only the CBCT, but also the laser. If you can have a 3D laser data or 3D photo data, that also can be used. You actually can superimpose the skin surface from the 3D photo to the CBCT, 3D CBCT, because the skin surface in the CT is not as good. So you can so-called superimpose and then obtain the 3D photo with the 3D CBCT. So these are the suggestion that I would like to have. And this actually has been very common in our practice, and certainly CBCT is should be available in your school. So I think CBCT is quite useful. 3D photo, there are also several different machines that allow you to have 3D photo. Expensive or less expensive, that also is helpful in terms of the evaluation and research, and also planning as well. And scanning, the dental scanner, if you have a stone model, you should scan the stone model. Also, you need a hardware, a small box, a small machine to scan the dental model. So I hope I answer your question.
Okay, thank you, Professor Low. I think it's such a detailed explanation about the Dr. Fadil question. If you have a feedback, you can raise your hand, or you can. Oh, we have another question.
You mentioned the computer aided design or surgical navigation, like this very expensive for simple technology. Okay. Well, if you have CBCT data, okay, you have personal computer, then you need a software, 3D software, to do the planning or simulation. 3D software, in my experience, the most less expensive and user-friendly is the Dolphin 3D. I think you should know the Dolphin software. Dolphin, this company, also had a 3D program to work together with the 3D CBCT. Okay, so if you do orthodontic surgery or in your dental practice, maybe dental implant, for example, if you have this image data, CBCT, you have software. Sometime in the there are also free software you can get download from the internet. That is a simple but free software, so you don't need to pay. So that should be helpful for your practice. We call if you need a simple technology. 3D printers, also there are less expensive 3D printer. Okay, but ideally you should use so-called the biocompatible 3D printer, because if you need to touch the patient, you need a biocompatible material. If you have the good outsourcing company that you can print the occlusal spring or physical model, you can also use that. Today in my presentation, I talk about you don't want to see it as a high-tech or very expensive machine. I think in the next coming year, they will become more and more available, friendly, and less expensive, because the progress of the technology actually become more and more friendly. Navigation, you don't need to buy the machine, because the machine you can borrow if in your hospital you have a neurosurgeon. I think some neurosurgeon, they have this branded navigation machine you can use. Or if you do not use navigation, you can use positioning guide or you can just use image. Okay, the image itself already give you a lot of anatomical information for you when you reposition the leaf-4 one. So move the, for example, I show you the leaf-4 one shortening or advancement, how many millimeter advancement. These are also good information that you mobilize leaf-4 one in the ideal place and then do the fixation with the plate and screw. So so you may start to use, just step by step. You do not need to, you do not need to spend a lot of money to buy expensive machines, but just step by step to that. How much you can use in my lab also. I also at some time when I have enough money, I buy the new machine or new software. Okay, so so it's what I mean is that if you understand the whole thing that I present, you can pick up something that when you can use in your practice, and then gradually maybe you have some other new equipment that you can use in the future.
Thank you, Professor Low. Maybe we still have one question. If you don't mind, I will read it for you from Dr. Anggun Mauliana. Thank you for your interesting presentation, Professor. I have two questions about this topic. The first is, can this treatment method be used in remote areas? And then, were there any challenges during the treatment of this case, maybe in the remote areas? How do you think? Yes.
In the remote area?
Yes.
Meaning not in your Makassar Makassar hospital?
Yes, maybe in the, because maybe
for example in Palais, Palais, is that right?
Oh, yes.
Well, right now, I think there's a telemedicine, or you just use your handphone, and then you can show the image to your friend. Actually, if you, for example, the orthodontic surgery, if you have data, CBCT data, you send the data to somebody somewhere or a company, then they can perform the surgical simulation for you. And through the telemedicine, for example, today you can see me. Okay, I show you step by step how I move the 3D image. Okay, if I'm an engineer, you are a surgeon. So now I move my maxillomandibular complex to this position. Are you happy? Do you want me change or shift or move to, or rotate? And finally, if there are agreement between you and me, I suppose you're a surgeon, then this is the final plan. Then I start to produce occlusal spring. Okay, and then I would mail the occlusal spring to you. So maybe 2 days later you can get my occlusal spring. Then you can perform the surgery. So in the in the remote area, from Makassar to Palais, maybe just 1 day, you can send the occlusal spring to your friend in so-called in the remote area. Or if you want to do consultation, this is my patient, I have image here, especially 3D image, and how do I manage the patient? Then I can give you my suggestion. And this is quite often that I'm doing here. I have fellows from many other countries, in even very far in Mongolia. They can also ask me questions from the internet. Yes.
That's really good, Professor. So maybe later we can send the image to you to maybe to have
Consultation, yeah.
yes.
And also, no charge, free.
Thank you, Professor. It's really good news for Professor Ruslin. So maybe I think there is no more question. It's really an excellent presentation, Professor Low, about 3D imaging. Maybe I can sum up a little bit from your presentation. First, the 3D imaging technology, maybe it's a sophisticated technology that developed nowadays, but maybe in the 5 or 10 years in the future, we will get used to this technology, and because it's really have advantages for the dentist, especially the surgeon, in the planning or evaluating the treatment, so we can get the result in the maximum one. Thank you, Professor. And then maybe I think that's all for this session.
Thank you.
Thank you so much. And I give back to the MC, Master Ceremony, Dr. Yaya, please.
Okay, thank you, Professor Low and Dr. Hajra. Maybe for Professor Low, can you choose one best question from the participant who also asked for you for the best question to get the special door prize from Polydent, from our sponsor?
I'm sorry, I don't. Can you ask the question again?
Can you choose one best question that already give to you from the participant?
Yes.
There will be door prize from our sponsor, from Polydent.
Okay. I think I have 3 questions here, right?
Yes. Can you choose one of them, Professor?
I think I choose this one.
Yes.
The social navigation, and like this one. Dr. Carolina?
Carolina?
Oh,
yeah.
Yeah.
Oh,
Dr.
okay.
Carolina.
Dr.
Carolina.
Okay, thank you, Professor Low. Congratulations for Dr. Carolina. You got the door prize from Polydent, and thank you, Prof. That's the lecture from Professor Low. Thank you, Professor Low, for the information and the knowledge. And we would like to welcome the Dean of Faculty of Dentistry, Hasanuddin University, Professor Muhammad Ruslin, to delivering the certificate to Professor Low.
Professor Low, thank you very much for your time.
Thank you.
And for your experience, very good, really excellent topic, and also you are a really good lecturer. So we would like to say thank you very much for your sharing knowledge and your opportunity. And we hope COVID-19 gone, and we come again. We can go into Pare-Pare again. With Ninja Turtle.
Ninja.
Thank you very much, Professor Low.
Yes. Bye-bye.
Bye-bye.
Thank you. Bye-bye.
Thank you.
Thank you, Prof.
See you.
Thank you.
Yeah. This is we deliver the certificate for the moderator, Dr. Gigi and Siti Hajira Yusuf, Master Science. Thank you very much for your time and for your guiding this session. Again, thank you very much, Dr. Hajra.
Thank you, Prof.
And I hope your success, your selection for the staff members in our faculty.
Thank you, Professor Rusli.
Okay. Once again, thank you to Professor Ruslin, Professor Lo, and our moderator, Dr. Hajra. Okay, ladies and gentlemen, next we will move to our fourth session. And before we begin the fourth session, let's see our moderator's profile in advance, as you can see by video on your screen right now. Okay, thank you. Without lingering, let's welcome our moderator, Yosi Yuanita Restina, DDS, Specialist and Consultant in Oral and Maxillofacial Surgery. For Dr. Yosi, time and screen is yours.
Thank you very much, Dr. Yaya. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen, all distinguished participants. Is my voice here loud and clear?
Yes, Doc.
Thank you very much. Thank you very much. It's been an honor for me. This is actually for the second time I become a chairperson for the 7th International Conference on Biophysical Technology in Dentistry this year, with the title or the theme Emerging Technologies and Interdisciplinary Research in Daily Dental Practice. In this session, I will become a bridging for one of our special main lecturer. She's now in a PhD program in Vrije University in Amsterdam for her brief CV or summary of her background. Oh, hello, Dr. Rifaat Nurrahma. Dr. Riri, how are you?
Hello, Dr. Yosi. Good morning in Amsterdam time.
Oh, okay. So what time is in Amsterdam right now?
7 a.m.
Oh, 7 a.m. in the morning. Oh,
yes.
Here we are 2 p.m. afternoon.
Yeah.
So
exactly.
maybe the committee will put on screen about your personal background.
Yes.
Please. Okay, thank you very much, committee. It's very nice for me to see you again, Dr. Riri.
Yeah. Thank you,
Okay,
Dr.
so for today's
Yosi.
session, you will have about 1 hour.
Yes.
Okay, thank you very much. You will have for about 1 hour in total, 45 minutes for presentation, and we will put another 15 minutes for a discussion. Dr. Riri, please, the time is yours.
Yes. I think I have a technical problem. I couldn't share my presentation. Maybe the host can help me to let me join us. Okay.
Okay, so Dr. Riri will present about the integrating digital technology into facial prosthetics.
Yes.
Okay, I can see your screen.
Okay. Okay, let me begin the presentation. Thank you, Dr. Yosi. So today I would like to present about integrating digital technology into facial prosthetics. So the background is first, there is no consensus what is the best, surgical versus prosthetic reconstruction. But however, prosthetic reconstruction has several advantages over surgical reconstruction. It can provide good aesthetic results in the short time. It's also less invasive and also alternative to surgery in suitable candidates. So also we have to compare with the conventional versus the digital. So how to produce or fabricate the prosthesis we can do in two way, in conventional and in the digital way. So I will explain what the different conventional and the digital one. So the aims of the aims of the study actually is to review the role of the different technology development in the maxillofacial prosthesis fabrication and how to explain the importance of the pre-surgical planning for the maxillofacial prosthetic and implant in the auricular, nasal, and orbital region, and how to demonstrate the advantages of digital planning and also how to realize and the advantages of digital planning over the conventional planning. How about if we discuss about the technology? So the technology enables more accurate placement of implants, so it can help us to where we can put the implant in the right place, and then also we can know where is the bone place to available to placement the implants. Also, it can help us between the surgeon, patient, and also the maxillofacial prosthodontist to allow to delivery the prosthetic of the best way. And also, the maxillofacial prosthodontist must decide the most appropriate method of transferring that data to get the best quality of prosthesis. So, this is the role, what kind of the role we can do to make a maxillofacial prosthetic. So first, we have a virtual record. So the virtual record we can find in two ways, with medical imaging and non-medical imaging. Medical imaging we can use like computed tomography or CT, MRI or CBCT. And non-medical imaging we can get from like using a laser surface scanner, intraoral scanner, 3D photography, or spectrophotogrammetry. So you can choose which one you have on your own hospital or your own lab. You can use for the digital one. So, and then after that, we do the modeling and designing with the kind of software. What we use here is normally with Mimic software. And then after that, we can fabricate it with rapid prototyping. So there is kind of also a rapid prototyping we can use. There is a selective laser sintering, we call it SLS, and then stereolithography or SLA, inject based system or 3DP, or fuse deposition modeling of FDM. And the outcome, it's could be two times. It could be to be a mold or to be a prosthesis. So this is we can discuss later how to combine this only from the mold, or it can be silicone prosthesis in the end. So if you can see, there is a prosthetic reconstruction we can use. As I say before, we can use a laser to capture the face like this. We can use the model scanner. So we use the model, and after taking impression, and then we can use also CBCT data or CT data to have a model. So this is the digital pathway to fabricated prosthesis. What we should do first in the consultation for the patient, surgeon, maxillofacial prosthetic. So that's the collaboration of the clinician. It should be done in the first time consultation. That's why the planning time is also should be done and before we did surgery, substructure, and to get the prosthesis. First, we do the patient consultation with development of digital models that are available to the patient both for the consultation or afterwards, so that it can be easy for the patient to understand the surgical and prosthetic procedure. So this kind of simulation, it can be like a photo, video, so we can get it in the first time when in the consultation begin. So this is for the planning data. This I want to compare. We can see together is the comparing conventional way and digital way. So if in the conventional way we use radiograph, we can use a photograph or an image or picture what before we use as a planning data. If they have like a pair of like a ear right or left, or if it unilateral defect, so we can use the photograph before the defect happen. And then we sometimes also use the physical model. So we taking an impression, and then we use physical models to do the planning, what kind of treatment we can do with this. And then in digital way, we use photographs also, but the photograph used in digital way. And then computer tomography, we can use it CT or CBCT. And then surface capture, we can use laser, and then a scanned model. So if you can see, this is a planning analog. This planning analog similar with the conventional way. So in the later, it's around 1990. We use rope or thread to have analog planning. So we need to take a thread to measure right and in the left part. And then this is also the conventional way that we have a templates for the soft tissue. So we draw it in the models like this, and then we try to put it in the patient when did the templates. So as you can see, this is a templates in the 2005, they still use the wax with the acrylic template. And then now we can also in 2012 it begin with the digital and use 3D printing to have models and then a guide to do the surgery for put the implantation. This is the planning 3D born guides. We use the mimics with simulation module, so we can compare or do the mirroring for this. So we allowing for exact positioning of implant if it's available. So we know how to put the or repositioning the ear here, right and the left. So we can do in that way. We can do the mirroring also with the mimics. So it's possible to us to do that way. And then we can have planning also with 3D bone-borne guide. So we can measure how many millimeter we can use and how many millimeter in this part. We use around 10.4 millimeter to have like a measure how long we can use this area to put an implantation, and then where is the site to put the implantation. Okay, the digital planning, ideal for complex planning cases. This is for the bilateral hemifacial microsomia, conductive hearing loss with a BAHA or hearing aid appliance, unusual heart and soft tissue anatomy, and also to the thin bone. This is we did the digital planning with soft tissue. Of course, we take with software. We still use the mimic software for this, and then we found this asymmetric midfacial, of course, here, and then we fix ear position in the left here, and then removal the remnant tissue, of course. So we know where to put on the exact place to put the implantation. And then we put it in the right side in 1.5 centimeter is lower, and ear from the imported from adult case in reduced 20%. Why we reduce? Because it's in the this is the kids program, so the kids patient, so we to get the ear, because this is the case of bilateral, so there is a left and a right defect. So we use the adult case to take that case, and then we reduce the big or the size of the patient. We reduce to 20%. And then we can now measure where the left implant placement. That one we use CBCT for this part, and then we can measure how long we can put the implantation. And then this is for the right implant placement, is also the same way. And the left side we use 3 millimeter, and then in the right side we use 4 millimeter for the right implant placement. So for the template design, we have to know the data imported into Freeform Plus. We use Geomagic from US here, and then the template design using haptic software. Template only 0.5 millimeter thickness, designed to engage curve anatomy, and also we need to make sure we avoid the facial nerve. Also, for the soft tissue template, we use stereolithographic resin. This is the final template of design. So this is the final for the right side, and this is for the left side. So this is two part. This is in the soft tissue one, and this is the green one for the bone, or for the bone to placement implantation. Here, as you can see, this is we plan as digital. This is the final prosthesis. This is we plan also with digital plan in the left side, and this is the final prosthesis. So we have both sides in the as you can see, for the kids, we have both sides in the left and the right side. This is also the prosthesis design we can use if we make the prosthesis only for the mouth. So we do need the hand carving for it. As you can see, also we use wax printed ear here, and then here the final prosthesis. So the way is we can use digital with and the conventional one halfway, and or we combine it. Then also we can use make a mold to create it in SLR resin, but for the silicone, we still make it in the conventional way. So how long we can get the digital prosthetic depends on the stage. So for the we try to compare which one with the conventional time and the digital time. So we taking impression in the first visit is the same time, but if you compare the wax sculpture or planning and for prosthetic, if you do in the conventional way, it takes 1 until 2 weeks. But if you do in the digital way, it only have in 1 until 2 days. Like after that, we have to try in to 2 or 3 visit. Why? Because for the conventional, we have to make it by your hand, and then if it not a fit, you have to make it again and with the waxing, and then you did it by hand mat. And but digital, and the only 1 visit you can try in, mostly it will be fit. And then in the liver prosthesis patient, it's will the same time in one visit. So the time needed for both, if we compare conventional and digital time, conventional needs 2 until 3 weeks, and with digital we only need around 1 week. So the conclusion of all of this one, how we introducing the digital technology is expected to improve the quality of the work of clinician, less reliant on the artistic skill of specialists, and more standardized work. Further study are needed to evaluate how effective the use of application of technology in facial prosthetic rehabilitation. Thank you. This is our research team, and we hope we can have a good collaboration. Thank you, Dr. Yosi.
Thank you very much, Dr. Riri. It's a very remarkable presentation. I mean, I see that the ear is really natural. I mean, it's really look like the real one. Even the color gradations. You know, in people in West, they have a very white, pale skin, and it's become reddish a little bit on the top of the ear. So it's really look very natural, and it. I wonder. I mean, it's the type of the material that's used in build up the prosthetic. Is it specific for the maxillofacial prosthetics, or it's just the same like for the other part of the body?
Oh, for the material, it's we have the same. We use the silicone. So for the material for prosthetic, we use silicone. But depends the kind of the silicone is depends of the weather also, of course, because it's different in here with for kind of weather, and in Indonesia or the tropical country, it's different. So there is any typical also for the coloring, the for the type of the also to have a different silicone type for the different areas, I think.
So but it is possible to be used in Indonesia, right? Even though we have
of course
weather.
That's why we start to reach also for the maxillofacial implantation in Indonesia, and also for the use the silicone there.
So can other than ear, can it also be used in other part in maxillofacial? I mean, maybe cheek perhaps, or nose, or eye?
Yes, of course. For maxillofacial prosthetic, we can use for in the ear, nose, and also the orbital part. And also sometimes we use for the finger. Also for the prosthetic, they use also anaplastologists also use it for the breast.
Oh, I see.
Also, yeah.
Implant.
So
Oh, not
yes.
really. Really implant.
Yeah. So that kind of a prosthetic we can make from the silicone.
For the defect,
yes.
For the defect posture.
Yes, of course.
Okay. Thank you very much, Dr. Riri. Maybe for the participant who have a question related to this topic, please, we are very welcome for you if you want to discuss about this kind of topic, because this is actually a brand new techniques for the reconstructions of the maxillofacial prosthetics, because as far as I know, here in Indonesia, we still use conventional with manual carving, or like I've seen your presentations about doing the analog printing. How I mean, I think in Indonesia we still use that kind of method, and if we move on to a digital way, then we could actually make the time for visit more less
shorter. Yeah,
yeah, shorter, and the time for treatment also shorter, and maybe the result is more satisfying than the conventional, if I'm not mistaken.
Yes, of course. So that's why from now we start everything begin from the planning, all of them using 3D plan, 3D print, also for implantation, to have a kind of
Yes.
Kind of have the kind of analog for to put the implantation in the right place in the bone.
Thank you very much, Dr. Riri. I also see that in order to wear these implants, you use the screw. Is it magnetic?
Yeah, for the here the implantation, if you use implant, of course we should use for the magnetic part to attach the prosthesis. But in if without implant, you need to use the adhesive part.
So it's like a
So
glue.
it's the different. Yeah, that's why it's better to have a implant, because there is no attachment, or there is no retention for the prosthetic if you didn't use like kind of mechanism or mechanical or chemical way to attach the the prosthesis onto the ear, nose, or orbital. So you can use in the two way, with the implantation with the magnetic part, or just using like a chemical part that's like adhesive. So it just put it adhesive, and then, or sometimes we also attach it with the glasses.
Oh.
It's also possible.
Which one is actually, I mean, if you prefer, which one is actually as for the interest of the patients? I mean, I imagine that if we use like a magnetic part, so we have to plant it in a part of the persons or the patients. You have to maybe choose the healthy tissue to put it, and we have to make sure that the magnetic implant that we planted on that anatomical part is not going to cause another defect in the future. I mean, should we better use the chemical, or I don't know. What do you think?
Yeah, it's in the different situation of the patient. So first, the clinical option also, and then the other from the patient, of course, because the better way is if we can use the implant. So a it's a good way to get a good retention. So it's also being natural. So there is no gap into the prosthesis also with the skin. So it's better ways with implantation. But as I know, also in Indonesia, there is still no kind of implant for the maxillofacial part. Of course, for the eye, ear, also for the nose. But I hope for the future, we can have it.
Hopefully,
Yeah.
we'll get in an advance, I suppose.
Yeah. Sure.
Thank you very much again, Dr. Riri. For any participant who still, if you have a question, you can fill the question box or the chat window, or you may raise your hand, and then we probably will give you a chance to speak directly to our presenter, to our speaker for today's session. We still have actually lots of time. Your presentation is quite short, so I think that you're going to take about, I don't know, 40 minutes at least. So, Dr. Riri, moving from the topic, how's the weather there?
Now it starts for a spring, so flower is everywhere now.
The bloom? Oh, it's very beautiful.
Yeah. Yeah, it start with the tulip time now.
Oh, it's very beautiful. How's the pandemic situations in Amsterdam?
So in here, there is no rules. So for now, all kind of COVID rules is disappear. So
Really?
even yes, so even on the tram, even on the public transport, except in the hospital.
No public distancing.
No.
No.
So
No. Wear a mask.
no. For now,
Really?
it's disappear. Yeah.
Even in
This-
indoor, even inside the
yes.
house or
So
inside the building.
yeah. So for now, all event can be held here. So
If there's any crowd, it's okay.
it's okay for now.
Wow, luar biasa ya. That's incredible.
So maybe in Indonesia, about in 1 month after it, maybe it's we hope.
Probably, yeah. Hopefully. Okay. We actually still have about. Wait a minute. We still have about 15 to 20 minutes actually. If there's any question, if not, then I'm going to ask another question to Dr. Riri. So, which one is more difficult? I mean, whenever you do or you make a prosthetic in maxillofacial abrasion, I mean, in my cases, I meet a lot of patient with tumor, neoplasma. Some of it is malignancy, and the other is the benign. So, and the other is probably the defect or the asymmetric of the face is come from the trauma, maybe accidents by car or motorcycle. So, you think which one is actually more difficult in making the maxillofacial prosthetic in some of the cases? I mean, that you ever perform or have in Amsterdam.
Yeah, because here is some more practical in that way with digital one. So I think the kind of the defect different. So as big as I found is all of them is taking away as like a maxillofacial defect in both part, maxilla and mandible, but they for now they have a 3D print for the kind of bone, like a substitute bone. Also they put it here, like they put it in the mandible also to change the kind of bone. So for now I think I think for now, as I can see here, there is no cases. It's difficult, but
Everything is easy.
our problem, yeah, because they have a good quality for the planning also, and then how to they treat the doing the treatment with the digital way. So that's our next maybe in the future in Indonesia, how to get in the digital way also to do the treatment. So we hope in the future we can do it in the same way, because what I found in Indonesia, of course we still need to make it in conventional way. We start also from the taking impression until to fabricate the prosthesis. We still need collaboration with the laboratory part. So this is so the lack of the material also, the clinician also need to improve their knowledge and their skill about how to fabricate it, the prosthesis. of course.
To make it their own.
Yes.
So nothing is difficult because now 3D plan make everything is easier.
Yeah.
Since I mean, make the planning become more accurate, if I'm not mistaken, as well.
Yes. Yeah, sure.
How long after? I mean, in a normal way, how long after the defect is happen before we plan to do the prosthetic?
Yeah, for the prosthetic, of course, we have the stage for them. So we have a first stage for the surgical prosthetic first. And then after that, we need to wait until 7 days to the defect heal. And then we need to wait until around 6 months until 2 years to make sure there is no recurrence time over.
Okay. So we still it still take times before we decide
Yes.
to make the definitive prosthesis. How,
Yes.
I mean, during that time, during that waiting time from 6 months to 2 years, so the defect is still in I mean, in the open area, or is there's any other option?
So now for now what I say before, we have a step. So the first step is for the surgical, and then after that intermediate, we call it intermediate prosthetic. So
is it the
yeah.
same like Optorium, right?
Yeah, so it's the same with interim. So for the intermediate prosthetic, we sometimes just make it like just use the material, simple materials. We use just acrylic or kind of them, and then after that, and after 6 months, we reevaluate the defect, and then we taking a patient again until we decide which one we can use the prosthetic way or in the surgery.
Oh, I see. So still have to, I mean, the best way is wait until the situations become in a optimum situations. I mean, like the disease is not happening again, there's no recurrence, and it's also free of infection. So maybe that we can start to do the prosthetic maxillofacial prosthetic steps, kind of that, if I'm not mistaken, Dr. Riri.
Yes. Yes, of course, Dr. Yossi.
Thank you very much. Thank you very much for your sharing and for your knowledge. And it's been a blast for everything that you have shared with us today in the 7 ICOBTD. And if there's no other question from the participant, I would like to close the session. Thank you very much for Dr. Riri. It's been an honor for me as your chairperson of today. And maybe we could give a virtual applause, perhaps. And I will return the session to the master of ceremony, Dr. Yaya. Thank you very much. Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Riri, for the good explanation. And now we would like to welcome the chairman of 7 ICOBTD, Israyani DDS, specialist in orthodontic medicine, to delivering the certificate to Dr. Riri and Dr. Yossi. For Dr. Isra, please. For the committee, Dr. Estra still unmute. Can you please unmute Dr. Isra?
opportunity to join with the great girl of Faculty of Dentistry at Hasanuddin University. I said girl. Okay, thank you very much, Dr. Riri, to participating and for your information maybe and for your knowledge to this seventh ICOBTD. Thank you very much, and we hope Indonesia can follow Netherlands when pandemic is disappear. Could you hear me?
Yes.
Check.
Yes.
Now it's better
Okay.
than before. Louder than before.
Oh, okay. So thank you again for Dr. Riri to join with us and participating in this seventh ICOBTD. You are great. And we hope Indonesia can follow Netherlands where pandemic era is disappear. Yeah.
Thank you, Dr. Isra.
Thank you, Dr. Riri. And the next for our guiders of this session, our chairperson. I like hear the talk show about this session. Okay, thank you very much for Dr. Yossi to guide this session. It's a
Thank you very much, Dr.
wonderful
Isra. It's been
session
an honor.
in the last session for today. And I think next session maybe will be great again when Dr. Yossi as chairperson to be talk show session. Thank you very much, Dr. Yossi.
Thank you very much, Dr.
And you
Isra.
look so beautiful today.
Thank you very much. It's been a pleasure for me. Thank you, committee. Thank you, chairperson. Thank you, the chair of the committee as well. Thank you.
Okay, once again, thank you to Dr. Isra, Dr. Riri, and Dr. Yossi. Okay, ladies and gentlemen, that was our session for today. And before we come to the end of the webinar, we will announce for the best question one more time. Here we go, and congratulations for Dr. Anggun and Dr. Caroline. And we would like to inform for the audience who got the best question to contact our committee at Secretariat of Faculty of Dentistry Hasanuddin University to get special door prize from Polydent. Congratulations and thank you for Polydent. And finally, allow me and all organizing committee to say thank you very much for your participating and attention in this webinar, and apologize if there is any mistaken in this event. Stay safe and stay healthy. See you tomorrow. Wassalamualaikum warahmatullahi wabarakatuh and good afternoon.